help address reproductive health outcomes in Louisiana in a number of different ways, including clinical care as well as education, which is what we're trying to do a little bit of this afternoon. So to date, two narrow approaches have really dominated the concept of adolescent sexual development in the U.S. over the past several decades, and that's been the abstinence-only approach and the sex as risk-taking approach. And it's important, I think, for us to understand that healthy sexuality and sexual development and growth is a natural part of human development. Healthy sexual expression is different than sexual risk, and same-sex sexual behavior is included in the realm of healthy sexuality. So looking back at the abstinence-only or no-sex paradigm, one of the concerns with this paradigm is that it provides a code but not empowerment. It gives limited tools for navigating relationships other than marriage, and it makes sex between teens hard to discuss when it does happen. And this is something that has come and gone to some extent with political cycles, but for most of us in the field, we probably remember it, especially during the Bush era. And I think one of the questions that arose during that era was abstinence until when? How long is this okay, or when can we have sex if we're not married? And that question was pushed actually to the administration back then, and they eventually, after a while, relented and gave an answer. And that answer was 30. You could not have sex with anyone unless you were married until you were 30 years old or older, which I think really goes in the face of what we know is the reality, which is on average adolescents are having sex about 16 and a half, 17 years of age. Used to be a tiny bit younger. It's not been getting younger since the 50s or 60s. It's actually gotten a little bit later. So it went kind of from the summer between sophomore and junior year to junior year homecoming. Not a big difference. Most people have had sex, or about 80% of persons in this country have had sex by the time they're 20. So that's way, way, way before 30. And 97% of Americans do have sex. So I think saying you can't do this until you're married or 30 really didn't make a lot of sense. And despite all that investment of federal funds at that time, there was no evidence that it was effective. In fact, there was some evidence that it was detrimental. The sex as risk-taking paradigm, which many of us that are healthcare providers tend to be a little more, set our foot a little more in this box, makes sex a disease rather than a part of normal development. It does not effectively distinguish healthy expression from risk, and it instills fear but not a sense of mastery and control. And I think this is one of the reasons why I took all the scary pictures out of all my STI talks, whether I'm giving those talks to residents for the most part or to youth, because showing really horrible images of sexually transmitted diseases has not been shown to be effective at preventing early sexual behavior or increasing condom use necessarily. And some local researchers actually have shown that it does increase shame but doesn't change behavior particularly. So and it also leaves out the pleasurable and relational context of sexuality. So when we just talk about risk-taking and don't really talk about what real sex is or healthy sexual development, we're really leaving a lot out that's really important. In current practice, again, this is medically derived and results in these discussions that are based on some narrow definitions of sexual health and focusing on specific behaviors as part of a risk assessment strategy instead of personal development and interpersonal relationships. So I know that as clinicians, oftentimes we do have to ask about specific behaviors and anatomy and those sorts of things. That does inform the way that we perform screening tests for sexually transmitted infections and those things. But I think we can still do a better job of asking those specific questions, providing good clinical care, as well as supporting development of healthy relationships. So shared experiences in adolescence. So across developed nations, adolescents go through similar developmental processes. This is not unique to the U.S. Schooling extends into the 20s, marriage in the mid to late 20s and early 30s. This is thought to be part of the reason that I think in the U.S. we sort of have this sense that adolescents are kind of engaging around sexual behavior differently than they used to, although they're having sex at about the same age as they always have, maybe a little bit later. they're getting married much later, right? So in the 70s, 60s, and 70s, the average age of marriage was closer to 19. Now it's closer to 27. So that's a longer period of time before marriage, even though first sex typically happens at about the same time. And we already talked about the average age of sex in the U.S. And in the Netherlands, it's about the same, 16 and a half, 17. So we're going to use that comparison to frame a little more of our discussion today, the U.S. and the Netherlands. So some of the reasons for doing that, they're both developed countries, they both went through a sexual revolution, and they both have access to high-level reproductive health technologies and things like contraception. Differences are different approaches to adolescent sexuality and very different sexual health outcomes, and some socioeconomic, racial, and ethnic diversity in the populations that differ a little bit. So this looks a little bit at the teen birth rate by country. So arrows look like they're a little bit misaligned on my screen. The bottom arrow should be lined up to the United States and the top arrow to the Netherlands. But in the Netherlands, in this chart, 5.2 was the teen birth rate. And at the same time, in the same time frame, it was 41.5 in the U.S. It's continued to go down in the U.S. since the 70s or since the 90s, really. We've had considerable decline in the teen birth rate, and since this data was initially published, it's gone down as well. In 2013, it was about 26.6, but so have the rates in these other countries. And so we've just never been able to catch up to the rest of the industrialized world in terms of our teen birth rates. And you can see the rate in 2013, when it was 26.6 nationally, it was 43.1 in Louisiana. In Caddo Parish, it was 54. It's about the same for New Orleans. So here's what I was talking about before. So in the 90s, really, we started to see this steep decline. About 86% of this decline is attributable to increased access to effective contraceptive methods in the U.S., not to abstinence. And you do see this little bump around 2005, 6, 7, 8 in the age of abstinence-only funding. So Dutch adolescents, they use contraception. Adolescents in the U.S., not quite as much. So looking at the chart on the left, use of any method, this is for the Dutch. Any method, 75 to 78%, looking over a couple of different year spans. And then condoms at all, about 66 to 68%. Pill at all, 17 to 16, and then other hormonal options at that time. In the U.S., condom rates were closer to 70 to 78%. I'm sorry, this is the Dutch side. And then the pill jumps up to 50 to almost 60% for girls, of course. And then use of both condoms and contraceptive pill. And this is what's referred to commonly as dual use. And this is really what is recommended that we be, advocating for, is dual use, using some effective form of contraception with condoms, in this case in a heterosexual relationship, as backup for STD prevention, as well as backup for the contraceptive method. In the U.S., we really have not pushed that, and to some extent that's thought to be related to the way that we framed quote-unquote safe sex in the 80s and 90s as being about using condoms for HIV prevention and really leaving contraception out of the conversation. And the rest of the world didn't perceive things that way. They were talking about both contraception and condom use simultaneously. So why are there such large differences? So it could be policies and economics and cultures. U.S. teens are more likely to be poor and lack good access to resources. Dutch teens have better access to sexual health education, which many of us know in our state is extremely lacking, and reproductive health services, which is also lacking generally across the country. And adults approach adolescent sexuality very differently because of a difference in culture. So we're going to look a little bit at that difference in culture through research and look at some of the cultural meanings of sexuality for adolescents. So these studies were done with Dutch and U.S. Parents as well as their teenage children from the early 1990s through 2000, looking at demographics that were similar, white, secular, moderately religious and middle-class populations. The interviews were a couple of hours, taped and then analyzed, and then they used semi-structured in-depth interviews. So you can see some of the kind of parameters there. So in the U.S., one of the themes that came out was that of dramatization. So the idea of raging hormones, sex as risk-taking, that there's a battle of the sexes going on, the idea that falling in love is extraordinary, and then secrecy between parents and teens. So for dramatization or raging hormones, this is an American mother saying adolescents are completely hormonally driven. So the issue with this is that it really assumes that adolescents can't control their urges, and that as parents, as healthcare providers, or other persons overseeing them as guardians or custodians of them, whether that's at school or other environments, that it's our job to sort of control and contain them because otherwise they can't control themselves. And what we know is that when we do that, even with young children and other behavioral issues, is that they learn that they don't have to control themselves, that we're going to do it for them rather than learning on their own. So that disjunction between the onset of hormones and the development of cognitive and emotional capacity to handle them is thought to make them uncontrollable. This is a 16-year-old American boy. So sex is a risk. You're definitely not looking to have if you're definitely not looking to have a baby, it's definitely a risk. I had a situation where condoms had broken, and I was like flipping out of my mind, ready to puke. It's like, Jesus Christ, we're dead. I'm screwed for the rest of my life. That's pretty dramatic, but I do think that this is probably a pretty common, feeling. And in fact, we use the term pregnancy scare in our kind of vernacular, both laypersons and in the medical community, frankly. And we say, have you ever had a pregnancy scare? And I think that that's probably related to this issue of dramatization. And then the battle of the sexes, so the idea that guys want to have sex and girls want love, and that consequences fall on females and parents must protect females and rein in males. And this has been shown again and again in different ways in the literature. In fact, in some of my early research around confidentiality, we saw this where parents also felt that they needed to protect their females, their daughters, and allow their sons to kind of have a little more freedom, or that they couldn't be controlled, but their young daughters had to be controlled and managed and protected against young men. Other research has really shown that guys want love too, and that there's actually a real struggle for young men growing up in the U.S., going from middle school or elementary to middle and into high school, and feeling a lot of pressure to have less intimate, less sort of romance or love-based relationships. And they feel like they have to give up some of their male-male relationships or other friend relationships to have these specific types of romantic relationships. And they feel like that they are special and that they really want love, but everyone else wants sex. So I'll let you guys read that. So this is not the T-shirt I saw when I was on vacation last summer, but it's the exact same language that was on that T-shirt. That one actually had a graphic of a mound of dirt with a shovel stuck in it that I thought drove the point home even more. So this idea that dads have to kind of have the shotgun or a gun, a shovel, and an alibi ready to protect their daughters is kind of, to me, an extreme version of this battle of the sexes perspective. And I think that the idea that I saw a person wearing this shirt while on vacation, and then I looked it up online for this presentation and found a different version of that shirt. So somebody's paying to have these made because they think that this slogan or whatever is marketable, says a lot about our culture and our society and how we perceive adolescent sexual development. And then there's the idea that love is extraordinary. So parents thinking, and this is a quote from a parent of an adolescent, teens just think they're in love. It's not real. Teens saying, I want to be in love, but other teens just want to have sex. So again, that comes out in a number of different studies that, well, I'm the oddball, I'm unusual, and maybe even frowned upon because I want to be in love, but everybody else just wants to have sex, when the reality is probably the opposite, that all of us really want love and understanding, and that parents think teens are just in love, that it's not real. And this is very different than the way other cultures look at this. And then sex being a secret. So, this is something we deal with on a clinical basis all the time. I just had 2 patients today where we had to address this issue. And I think it's, unfortunately, in a clinical environment, we have to respect our patients, but at the same time, when they don't want to inform their parents about some of their sexual development and behaviors, we recognize that may or may not always be the healthiest thing long term. So my mother hasn't asked me whether I'm having sex, and I haven't told her. I'd rather her not ask me straight out. So teens keeping sex as a secret and parents preferring not to know, which we see a lot when the issue of sexual education comes up, when it comes up in the legislature. Oftentimes you have legislators saying, oh, parents don't want you to teach their children about this issue, or this is to be done at home. And we know that it's not happening at home. And we know that parents maybe would love to be able to discuss these issues openly with their children, but in our culture it rarely, if ever, happens. And secrecy weighs especially on girls in this realm. So let's turn to Dutch culture a little bit and adolescent sexuality and the normalization of adolescent sexual development. So in the Netherlands, there's this idea that adolescents can self-regulate and that they have a period of readiness. Sex is preparation for adult relationships, preparation for relationships in which sex may be related to childbearing and other things, and that falling in love is common, that there are relationships between the sexes and learning how to have those relationships is important, and that normal sexuality is not secretive. And I would say that this, given that I'm giving this talk from an inpatient adolescent psychiatric facility, that one's key to me, right? So for my patients, when it's a secret and no one knows about someone, I'm very concerned. So readiness and self-regulation. So this is a Dutch father. Think about this versus the American dad wearing that T-shirt. My daughter is 16, almost 17. I think she knows very well what matters, what can happen. If she's ready, I would let her be ready. So the idea that teens can self-regulate and the concept of being ready, I had to take out the Dutch word for that, I couldn't pronounce it, but parents stress that sexual development should occur gradually, just like everything else. And I try to press this on parents and other providers that, relationship development, the building blocks that go into that, sexuality and exploring one's sexual self and relationships, it's not that different than learning math. And we rarely, if ever, think it's a good idea to hold back basic mathematics skills like addition, subtraction, or algebra and geometry until someone decides to go to graduate school and become an engineer and build our bridges and highways. We generally would like them to have a little bit of information along the way throughout a long period of development. And most of our students up through high school get that same information even if they don't go on to build bridges. So, and it's not considered wasted. So, and then the concept of version or range of behavior that's not limited to intercourse. So for us, we have very, specific sort of, well, I don't really know what it means to be a virgin in the U.S., but everybody has certain concepts of, well, if you do this, you are, and if you don't do this, you will maintain that status, and if you do this or that, you will lose that status. Sex is preparation. So this is a 16-year-old Dutch boy. Compare this to the boy who was flipping out. It goes without saying that you use them, contraceptives. Not even just condoms, but again, contraceptives. Preparation is part of readiness, so being prepared, and the contraception and condom use are expected preparations for sex. So, I did have a patient recently who said that he's a twin sibling with a twin sister, both about 16, 17, and his mom keeps a box of condoms on top of the refrigerator. The box is empty or gets low. She goes and buys more. No questions asked. That's it. She just makes it available. And the normalization, that falling in love is common. So that being in love is a common experience, including for teens, and that 63% of Dutch youth say they're, quote, very much in love with their current partner. This is really what you want to support. Now, we know that adolescents feel very strongly about their partners, but again, oftentimes in our culture, we sort of dismiss that as we use terms like puppy love and other things like that. It may not be their last relationship, it may not be the final relationship, but every relationship that our young persons are in, we want to support that being the most important romantic or interpersonal relationship with that partner or any partner that they're having at that time. And then the idea that if they really have something special with someone and then sex happens, well, who am I to object? So this is a Dutch mother. So sex is a normal part of relationship development. It's a normal part of developing intimacy with someone. It's a normal part of, the way we develop intimacy is to share ourselves and make ourselves vulnerable to other persons and have that person accept us. And if they don't accept us and reject us in some way, then the intimacy wanes or is eliminated. And if they do accept us, intimacy grows. But this reflects mutual desires and interests, and parents are supportive of these relationships, not supportive of casual sex. So there's actually an expectation that parents of adolescents that are engaging in a relationship, that they will discuss that relationship and kind of where it's headed with their parents, that the parents of the two youth will have some communication, and that as that relationship progresses, those two sets of parents will actually have a conversation and allow for what in our sort of terms might be called a sleepover, and sex happens in the home. So there's sort of permission given to allow for intercourse to occur in the context of a relationship with adolescents in the Dutch culture, and it happens at home. And I think that's a very different paradigm than here, where because we say not under my roof and hold adolescent sex at arm's length, sex happens in cars. I mean, that's an iconic image in the United States, that you have sex in a car. It was in American Graffiti. It's also horribly in The World According to Garp and other books and movies. And, I think that happens only because it's not allowed somewhere else that might be a lot more comfortable and certainly safer. And a lot easier for parents to monitor, technically. So normal sexuality. So it should be normal to talk about during dinner. So that's huge. Can you imagine having regular conversations? It's going to happen in my house, much to my wife's chagrin, although I think she's okay as long as I'm the one leading those conversations. But having it happen during dinner is not the typical American experience. But the idea is that sex should be normal and acceptable part of life, should not lead to secrets, and should not cause conflict between parents and teens. And that's a negotiation. So this 16-year-old Dutch girl saying, I wanted to tell my mother, I don't know, it was on my mind, so I told her regardless of the consequences. So she recognized that in whatever circumstance she was in, there might be some consequences, but she also felt like the right thing to do was to tell her mother, as opposed to maintain secrecy. Parents may not always be completely comfortable, but they'd rather address the issue and discuss it rather than having secrecy and deception. So can we use some of these cultural approaches, and can we change them and change those cultural approaches to adolescent sexuality? And I think we can. I think that, again, embracing the idea that it's a normal process of development, it happens along a continuum as youth mature. So again, that sort of mathematics analogy, that as adults we play vital roles in providing resources and supporting the development of skills, and then incorporating this into healthcare, education, and parenting can hold great promise. So I'm going to go through a little paradigm, a little conceptualization of a paradigm that can be used, that came out of Dr. Shalat's research, which is what I was just presenting. So this is the ABCD squared paradigm for healthy sexuality: autonomy, building connectedness, and addressing diversity and disparities. So again, it's a normal process of development. It's a continuum, and adults play vital roles. So one of the first things I think we all have to do when addressing adolescent sexuality, or to change the way that we interact with youth and adults around this topic is to do our own values clarification. So we need to be aware of our own feelings about adolescent sexual behavior. I was just having this conversation yesterday with a clinic manager talking about how we need to change the interactions between the persons that answer the phone to schedule patients to an adolescent health clinic, and how training them may involve doing some values clarification, because when a sexually active adolescent calls to make an appointment for a clinic and says that they want to make an appointment for contraception, that potential mother, grandmother, sister, cousin may have her own very strong feelings or his own very strong feelings about whether or not that's okay, but they still have to do their job. How comfortable are we with talking to adolescents? What are our feelings or beliefs about adolescent sexuality? And can we separate those values and beliefs effectively to counsel the patient, or to just accept a visit to our clinic, which we discovered maybe we were missing some patients along the way. So we'll use the case of Janice. She's a 16-year-old young woman. She's decided to have sex for the first time, and she's asking where her boyfriend can go get tested for STIs. I'm applauding Janice already. So developing autonomy of the sexual self. So this is the A. So research has found that personal control and self-efficacy and sex negotiation are significantly associated with safer sexual behavior. So if persons feel like they have a sense of control over their lives and in general, they're more likely to maybe abstain from sex or to use condoms when they engage in intercourse. I see this on a daily basis with my patients, particularly my patients that are in situations that I might describe as, to use that term, that risk-based paradigm, riskier. Oftentimes they really don't have a sense of autonomy or control around their sexual lives. And sexual subjectivity or sexual body esteem and sense of entitlement to pleasure, self-reflection around sexual activity are all associated with higher levels of self-efficacy and condom use for girls. And girls who report more sexual self-efficacy or have a higher ability to act upon their own needs are more likely to have used condoms the last time they had sex. So some ways to respond to Janice and her service request, thinking about how we could assess her autonomy and how we could create some positive communication about sexual decision making. So we can kind of get into that a little bit. Don't have the face-to-face question and answer ability during the webinar. So assessing understanding of anatomy and reproduction and contraception. So that can be important, just at the most basic level. And then identifying where patients are getting information. So I had a young lady I just saw maybe an hour ago who most of her sexual health information was coming from her slightly older 16-year-old sister, who never used the term sex. She used the term humping, and the young lady was very confused when I was asking about oral, anal, and vaginal intercourse. She wasn't even sure I meant what her sister described as humping, and then she told me, I asked about abuse and rape, and she told me rape is when you make people eat food that they don't want to eat. So identifying sources of information and bridging gaps through education, those were some big gaps. But I think many of our patients and many of our young people have other gaps that might be important. So assessing self-efficacy in other domains and problem-solving abilities. So some of our patients may be more limited than others in their problem-solving abilities as well, and we have to address that. Acknowledging the pleasurable, enjoyable aspects of sexual contact. So I think this is something I train residents and medical students to do when they take a sexual history, is to ask, are you enjoying the sex that you're having with your current partner? And the first time a patient hears that from a physician, I think they sometimes are kind of surprised, but I think that the other side of that is, that's what it's supposed to be about. So if you're not enjoying it, then you really have to be somewhat self-reflective, figure out why that might be. Is it something about the relationship? Are you not using condoms and you're anxious that you might, become pregnant or have an STD or something like that? Or you, feel like your partner's not as respectful as you'd like? Or are they not doing something that is pleasurable to you or doing something that is uncomfortable? So I think that recognizing that, and also recognizing the intimacy building and some of the other things I mentioned, that's what sexual intercourse and sexual relationships, a large part of what it's about. So it should be enjoyable even for adolescents. It certainly should not be unpleasurable. And then normalizing desire and arousal. Those can be normal, but you don't have to act on it in the middle of class. So I think that, you know, the idea that raging hormones sort of take control of adolescents and they turn into wild people, you know, couldn't be further from the truth, but also recognizing that desire and arousal is a normal experience. And then emphasizing owning and controlling one's sexual decision-making and helping youth examine their readiness and promoting preparation. So the B, so building good romantic relationships. So I think, to me, this is in some ways a core piece. So research has found that communication with partners about contraception prior to the first time they have sex significantly increases the use of contraception, whether that's for boys or girls. Unfortunately, in this country, the average time frame between onset of sexual intercourse and a visit for family planning or contraception services for young women is 14 months, which last I checked is longer than the gestational period for human beings. So unfortunately, we could do a much better job about this, and having open communication for dating couples increases communication about contraception. So that's something that I always try and encourage my patients to do. One of the things I say is, do you talk to your partner about sex? Do you talk to your partner about what feels good? Do you talk to your partner about contraception? And have you talked to your partner about if and when you might want to have children one day? Doesn't mean that they want to have children with that partner right now, but if they say, well, I want to be 22 and they're 16, and their partner says, well, I want to have kids right now, then that's an important communication or important discussion to have. And oftentimes we see that the friction and sort of bad events and bad things that happen arise out of just some lack of communication or misunderstandings about expectations. That's probably almost every situation for all of us, right? And then we know that adolescent sexual activities are more likely to be safe, wanted, and pleasurable when partners are generally more equal in age. We oftentimes use age for a proxy of power, although it doesn't always hold up. Teens are satisfied in their relationship, and they experience intimacy in their relationship. And I talked already about the building or developing of intimacy being to a large extent related to our allowing vulnerabilities and then having that be accepted by others. And that's, again, in almost any relationship. So discussing peer relationships as lead-ins to romantic relationships. And so again, this has been studied by another researcher looking particularly at adolescent young men, but she followed them from middle school or elementary through middle through high school, and talked about how those peer relationships, you know, the skills that you develop in those relationships lead to hopefully better communication in romantic relationships. And the value of relationship building in and of itself, the virtues of intimate relationships. And encouraging youth to discuss what is a healthy relationship. And I heard one of our social workers here one time ask about a partner, would you say he's a good guy? And the patient said, yeah, I would say he was a good guy. Okay, what makes somebody a good guy? What makes a good partner? And, you know, actually have the person kind of list it out. In that case, that young woman was able to really come up with some nice ideas. Communication with partners, which we discussed, sex-related communication specifically, and then conflict resolution. So there's always going to be conflict, misunderstanding, partners that are in different places around different issues, and how do we resolve those conflicts? Is it a fight? Is it, you know, storming out? Is there violence? Or is it a discussion and we come back to it? So what do healthy relationships look like to us? And then disagreements or arguments being a normal part of any relationship. We talked about that. How often are you and your partner together? How does your partner feel about hanging out with other friends or family? I would add that probably too. So I think that we recognize that some of these are questions to ask around relationships that might lead us towards more dangerous relationships or intimate partner violence, and other ones are just, you know, road signs towards healthier versus less healthy relationships. And if sexually active, who makes decisions about when to have sex, what kinds of contraceptives are used, those sorts of things. So I think, again, this is empowering all of our patients and youth to have shared decision-making and some self-efficacy and autonomy around this type of decision-making as well. And then connectedness between adolescents, as well as their parents and other caregivers. So this is Eric. So Eric, he's 15. His mom's concerned he's having sex. She requests information on pregnancy and STIs that she can give him to encourage abstinence. You know, he's a recent patient whose mother keeps a box. Oh, I mentioned that already. So I thought that that was kind of different than Eric's mom here, who's trying to encourage him not to have sex. So connectedness. So research has found that maintaining connectedness with parents and guardians and other trusted adults is important for many aspects of adolescent health, including sexual health. So oftentimes I have parents tell me, well, their friends decide everything. I mean, they don't listen to me anymore. So yes, on average, peers have a great deal of influence over the behavior of individual adolescents. A little more than about 50% of that influence resides in peer relationships, but parents still hold 40-something% of that generally, and so that's not insignificant, even if it was 25%. I think that as parents, as trusted adults, many of us as healthcare providers become trusted adults for our patients or trusted providers and have some influence. And I think we can't just abdicate that. And maintaining connectedness, we know, is a big piece of that. We know that connectedness is essential to behavioral health, mental health, and emotional health for all of us, and maintaining that with parents and guardians for adolescents is critical. And we recognize that parent and teen communication about sex has positive impacts on teen sexual health. When they have a close relationship, communication is frequent rather than one-time, and teens feel their parents are open and comfortable in discussing the topic, so they can be approached when issues do arise. And you know, I think that ice-breaking moment, that having that first conversation, but making sure that it's recognized right up front that it's not the last conversation, can be really critical. But it's hard, like I mentioned before. You know, talking to legislators who say, we don't want you talking about this, and we don't want you teaching about this. It's something to be done in the home, and it rarely does happen. One of the critical things that I tell parents to do is just start talking. Just set aside time on a Saturday from 1 to 2 every Saturday, and everybody's going to be squirming at 12:40, but just set aside that time to talk about whether it's sexual health, substance use, peer relationships, relationship building in general, future career and academic plans, whatever those difficult conversations are, and just keep doing it every weekend. And maybe you mandate that there's no earbuds, but you can't mandate eye contact. So you just have the conversations until they become routine and almost boring. So in this study, adolescents 12 to 19-year-olds reported that parents were the greatest influence regarding sexual decision-making and value. So on that specific issue, in that age group, in that study, parents had a greater influence than peers. And nearly 87% of adolescents agreed it would be easier to postpone sexual activity and avoid pregnancy if they're able to have more open, honest conversation about these topics. So again, parental influence is key, and maybe this is, again, one of those areas that unfortunately all too often we avoid and abdicate our responsibility and our ability to have influence. So for Eric, how do you respond to Eric's mom and her concerns about STI information and promoting abstinence? And how can clinicians foster some communication? So think about those issues and what other adults might be in Eric's life to give support around sexual decision making. And I might ask that of the mother as well as Eric. I might, say, Mom, is there anybody else in Eric's life that you think he looks to for important information that he could talk to about this, including persons that might have different views than you? And I would probably allow that, because one of the issues with abstinence-only education or that approach, at least from a sex ed perspective, is, again, there's no room for any other option. So if you've already had sex, whether it was, consensual or it was abuse or rape or some other situation, and you're in that classroom where that is not allowed, and the message is that is wrong, then who are you? Where does that leave you as a person? And so while it's not our job as healthcare providers to structure the moral, social, cultural context in Eric's family, I think it might be important to give Eric, some options where he could, with whom he could discuss these issues aside from just his mother. And then how might that encounter have differed if the mom was concerned about the daughter rather than a son? And how might we promote the concept of a relationship between sexes in that encounter? So again, connectedness, the caregiver role in education. Parents usually are not the primary source of information. I mentioned an older sister a little bit ago. Many parents feel unsure about how to best approach a topic or content, so we talked about that. And avoiding the one-time big talk, and then making sure that communication about sex over time builds up to be more extensive. Oftentimes we recognize it's not. And then parent and teen conversations often being one way. So this is something I have to avoid with my son, right? I need to avoid talking to him, and I need to try and talk with him. So how can we do this? So you want to avoid a parentectomy, and that includes in the clinical environment, but we want to encourage open and honest communication, if possible, between caregivers and teens. Encourage parents to communicate their values and beliefs, but recognize their children may have different values and beliefs, different perspectives and experiences. So again, we don't provide the moral, social, cultural context for our patients. We recognize that they live in a different moral, social, cultural context, but we also can provide information to parents and other adults that those teens may not also live 100% in their moral, social, or cultural context. Their experiences at school with other peers, their experience growing up now versus 20 plus years ago, all mold their moral values. So talking to adolescents, thinking about their perspective in their relationship with a caregiver, examining behaviors for conversation, and then offer to be a resource to both parents and teens. So I had a pretty difficult case at the end of the day yesterday, and I think that the most important thing we could do, as difficult as the parent in that particular situation was to continue to say, we'll be here for you, we'll see you in 6 months, call us if you want to come earlier, those sorts of things, even though it's a difficult situation. I could have said come back in a year, but we want to be available, and that connectedness and those multiple opportunities to address issues gives us the best opportunity to influence things. Acknowledging that to caregiver that talking about relationships is difficult, but it's healthy, and then helping caregivers understand the importance of modeling healthy relationships. So I think that that's important too. Oftentimes, parents may not be in the best relationship themselves, and how do you model that for your child? How do you model giving them the kind of relationship you'd like them to have, not just the kind of relationship that we ourselves may have? And then the last part of the paradigm, so diversity and disparities. So research has shown that poverty and lack of access to socioeconomic and other health resources definitely negatively impacts aspects of adolescent sexual health, including STD and HIV rates. We see that dramatically here in the poor South, parts of the South where we don't have access to good services. Pregnancy rates, predominantly due to lack of access to contraception, and then education, contraceptive use itself, and then teens' feelings of self-efficacy. So again, I think as a society, and certainly from a business perspective, we've gotten away from the concept of cultural competency, because we recognize we can't all be competent around every culture that we're going to encounter, particularly as healthcare providers. So having some humility and recognizing that that's the case, and then doing some patient-centered interviewing. How do the things that we've just discussed interact with your community or culture? Is this accepted? And I've had, as hard as some of the work here in this inpatient adolescent psychiatric facility can be, it can also be really rewarding, because we see patients from all of Louisiana and multiple states surrounding Louisiana, and while many of the issues that bring them in seem to be the same on the surface, each individual patient's a bit different, and oftentimes the cultural influences in their specific family or regional cultures come to bear in the issues that brought them here, and then particularly around their sexual health. So we want to avoid generalizing based on our knowledge of some cultures and communities, and patients can communicate the role of culture in the encounter. So I ask them, like I said, how does this relate to your culture? How does your culture relate to you? You're transgender woman that is at a 50-person high school in rural Louisiana that's interested in transitioning. How does that go over at school? How does that go over in your community where there's 6 churches and 1 high school, and there's 2 Catholic churches and the rest are of a different faith? Those issues can actually be important as well. And recognizing diversity and disparities in practice. So how do we create best practices for diverse populations? So, and how do we utilize knowledge about health disparities in communities without making assumptions about individual patients? So we don't want to say the state is poor, the city is poor, our patient isn't going to get what they want, or isn't going to get what they need, I should say. And so I think that we need to not make assumptions about our patients and about their communities. We need to ask. And then, so where's the patient in their sexual development? How do cultural or religious beliefs play into patient values? What barriers exist for patients to access health services? And are providers barriers themselves, our personal beliefs and stigma? And how do socioeconomic forces shape patients' experiences with clinicians? These are all can be important things to explore. And, again, going back to cultural and religious beliefs, the other thing, and back to this slide here about making assumptions, you can make those assumptions in either direction. And one of the cases that I always talk about, I saw as a fellow, was a young woman that oftentimes came to the general peds clinic, even though she was an adolescent. We had our general pediatricians and the residents seeing adolescent patients there too. And oftentimes, if they were sexually active and other things, they would turf them over to us in adolescent health. But we had a general pediatrician out one day, and this young lady came into our clinic for her regularly scheduled appointment. She always had on very conservative black clothing, her little glasses, her hat, and her Bible in her lap. Every single time, we'd always kind of see her in the waiting room, and we always kind of would ask ourselves, I wonder what her deal is. And now she's in our clinic, and we're going to see her, and my colleague went to see her first and then came out and told me that she needed me to come in with her. And the young lady had a number of STDs, had pretty significant history of sexual abuse and some other things, and it had never been uncovered or addressed, primarily because of the way she dressed and looked, the idea that none of these questions needed to be asked and none of these things could possibly be issues for her because of her parent religious upbringing. So looking overall at this paradigm, normalizing adolescent sexual development like we talked about, providing access to comprehensive, accurate reproductive and sexual health care and information, promoting and affirming discussions about sexual feelings and arousal, helping patients develop some self-efficacy and autonomy around decision-making and responsibility for their decisions, as well as developing stronger, healthy relationships. Changing from a parentectomy, removing parents from the conversation, to a parental involvement conversation where appropriate or wherever possible, and reframing our research focus to go beyond risk to help inform and support a paradigm shift. So again, this goes back to some of the things we talked about, but sexual development's natural. Cultural approaches can affect clinical practice and patient outcomes. The traditional approach in the U.S. is primarily one of risk assessment, and the new paradigm that might be needed to recognize healthy sexuality beyond abstinence and risk can be performed. And we can advocate to normalize adolescent sexual development and provide youth with necessary resources in lots of different environments. Thanks.
Great. Thank you, Ryan. At this time, if anyone has any questions, you can enter them into the question box. I'll give y'all just a minute if we have any. Okay, well, it doesn't look like we have any questions right now. Of course, you can always email us or Ryan with any questions after the webinar. You'll get a follow-up email that will have that contact information. We want to thank Ryan or Dr. Pasternak again for participating and for presenting today.
Thanks, John.
And we will be having another webinar in May on reframing teen pregnancy and changing the conversation around expecting and parenting youth, and then another one in June around healthy male development and identity. And those will also be sent out later. We want to thank everyone for participating today, and enjoy the rest of your day. Thank you again to Dr. Pasternak.
Thank you all.